So the standard approach by most gynecologic oncologists for a patient like this would be to treat them frontline with gemcitabine and docetaxel. There was data recently presented at ASCO that showed that you got equivalent outcomes and probably less toxicity using doxorubicin up front when in a head-to-head trial. Now with the addition of Olaratumab, there is an abstract that was being presented by myself and Robin Jones looking at the outcomes of uterine leiomyosarcoma patients being treated with adriamycin and Olaratumab, and they had the same overall survival benefits as every other patient in this trial, with about a year overall survival, with the addition of Olaratumab to doxorubicin. And so now it becomes kind of this new conflict, which is in a field that's very well established where frontline therapy is gemcitabine and docetaxel. I think by the time a lot of these patients either get to a medical oncologist or that specializes in the treatment of sarcoma, you may find a little bit of conflict. But whether this is used frontline or second line, I think there's still a lot of added benefit because in the phase 2 trial, most of those patients received their doxorubicin with Olaratumab, not frontline. So the addition of this monoclonal antibody to an anthracycline really begins to change our approach to the treatment of soft tissue sarcoma. I think traditionally we had two possibilities based on some older data. A lot of sarcoma doctors you combine ifosfamide with doxorubicin. The others, based on data that showed equivalence, would use doxorubicin and ifosfamide separately because there's data showing kind of equivalent overall survival. But if you look at it, response rates are higher in combination, and so there was kind of an art to what you were trying to accomplish. Bringing in Olera, we now add a third path. And so you have those of us that would use doxorubicin frontline as a monotherapy. The doxorubicin with ifosfamide, which still has a higher response rate, so depending on what you're trying to accomplish, isn't in a regimen that's going to completely go away. Or now, which is probably now the standard of care, which is doxorubicin with Olaratumab for widely metastatic disease in patients where, in general, you're trying to palliate them and not cure them in the stage 4 setting. So my clinical experience with Olaratumab goes back to about 2010. About just under 25% of the people that were in the phase 1-2 trial were actually put on at my center, and I knew all of them very personally. And so what was really nice was actually the side effect profile of the addition of a monoclonal antibody to doxorubicin. And what was even better were the patients that made it to maintenance and stayed on it for quite a long time. We had some patients that were on it for years. And the quality of life on maintenance was amazing. If you looked at the really prolonged tumor stability that the combination gave a lot of our patients, it really did, apparently, if you look at the actual data, give the whole population of patients we treated an overall survival benefit of just under a year. And that's just outstanding for a therapy that is just compared to doxorubicin and ifosfamide, just clearly superior from a side effect standpoint. And so if you look at each and every person across each and every different histology, there were patients whose tumors shrank late, there were patients who really tolerated this well. And I really feel like this is a nice therapy to add to doxorubicin, which we're just going to frankly give anyways. And so most of these patients that went on these trials using Olera in the beginning were actually metastatic. Not that many were locally advanced at our center, and so I really like this as a therapy for metastatic disease because of its tolerability and the fact that now we have a clinical trial showing that it looks like it has a lot of efficacy at the same time. But what I really think that is important, though, is to look at the design of the original phase 1/2, which was actually 8 cycles of doxorubicin as opposed to the standard 6 that a lot of people are actually used to giving. And so there was additional anthracycline given, which may actually be important in giving you this overall survival. And so getting people comfortable with the use of dextrazoxane is actually important, because if you go out that far, you do have to much more worry about heart damage than you would normally. And so if we're going to push, I think we actually have to work as a bigger unit to make sure that we don't do a lot of heart damage while trying to give patients overall survival. So one of the things I've seen as patients come to a center of excellence from out in the community is sometimes there's novel approaches given in the front line which aren't necessarily based on doxorubicin. And so whether it's one of the newer drugs given not on label, say whether we gave, say, trabectedin frontline as opposed to a doxorubicin regimen, which was how the original Yondelis trial was written, or if patients were given pazopanib up front because it was oral, because they didn't want to do chemo, one of the questions comes up: should you add olaratumab to doxorubicin, say, 4th line? And based on how the original phase 2 part of this trial was designed, the answer is yes. And what we saw was that it's important to add this to doxorubicin, not necessarily the line that it was given. We saw higher response rate the earlier doxorubicin was given, but I think that's the response rate to doxorubicin. And so whether you use this front line, which would probably outside of uterine leiomyosarcoma become a standard of care, or 2nd or 3rd line because they hadn't seen an anthracycline, I think it's important to use in combination.